I'm Margot Hudson with the Diabetes Management Service at Brigham and Women's Hospital, and the next session will be about diagnosis and management of hyperglycemia in the ICU. I have no disclosures. The objectives of this session are to understand the pathophysiology and diagnosis of hyperglycemic crises, to understand the components of acute treatment for hyperglycemic crises, and to review management of non-critical hyperglycemia in the intensive care unit. I'd like to start with a case of a 71-year-old woman who was admitted to the hospital with hyperglycemia. She stated she had 2 to 3 weeks of polyuria and polydipsia with the new onset of a pruritic groin rash. Her past medical history was significant only for hypertension, and she was treated with an ACE inhibitor and a calcium channel blocker. Her family history was actually negative for diabetes. She was not a drinker. And a review of her records showed that she did have a random blood sugar about a year prior of 156. On admission, her physical exam showed her to be obese with a weight of 109 kilograms and a BMI of 42. She had candidiasis, but otherwise no infections, no myocardial infarction. Her laboratory studies are here: sodium 121, potassium 5.9, chloride 80, bicarbonate 15, BUN 34, creatinine 1.32, and her blood sugar was 840 milligrams per DL. She had a beta-hydroxybutyrate level drawn of 5.18, with normal being less than 3, and an A1C was drawn, which was 15.3. Her measured serum osms were 311. So what are the diagnostic categories for a hyperglycemic crisis? First, we have diabetic ketoacidosis, in which the predominant abnormality is ketosis with acidosis in the setting of hyperglycemia. And second, there is hyperosmolar hyperglycemic syndrome, in which the predominant abnormality is dehydration due to hyperglycemia in the absence of acidosis. Insulin deficiency, relative or absolute, underlies both of these crises, and they can occur in patients with type 1 and type 2 diabetes. This shows the overlap of many of these metabolic disorders involving hyperglycemia, ketosis, and acidosis. At the center, we have diabetic ketoacidosis, but hyperglycemia can also involve hyperosmolar state, here called non-ketotic hyperosmolar coma. Acidosis can involve many other conditions, which we will discuss, and ketosis can involve alcoholic or starvation ketosis. So the accepted diagnostic criteria to distinguish DKA from hyperosmolar hyperglycemic syndrome, or HHS, include glucose levels. Generally in DKA, glucose is over 250 milligrams per DL. However, I think it is important to point out that DKA can be seen in patients with lower glucose levels. This has been well described in pregnancy, and now with the use of some of the newer anti-hyperglycemic medications such as SGLT2 inhibitors, DKA can be seen with lower glucose values. In HHS, generally the glucose is above 600. Arterial pH in DKA should be below 7.3, where in HHS patients are not acidotic. Bicarbonate in DKA generally is below 18, and in HHS it is over 15. If checked, urine or serum ketones will generally be positive in DKA, where they are negative or only trace positive in HHS. And just remember, I'll mention this later as well, that the urine and serum ketones are detected with the nitroprusside reaction, but the very first ketone to be produced is actually beta-hydroxybutyrate. This is not picked up by the nitroprusside reaction and must be checked independently. And this has been found to be associated with levels greater than 3.8 millimoles per liter are associated with DKA. Though, again, this is not, beta-hydroxybutyrate is not a standard measure for diagnostic criteria. In HHS, beta-hydroxybutyrate will not be elevated. Osmolality can be variable in DKA, but should be elevated in HHS. And anion gap in DKA will be elevated, certainly above 10, usually much higher. And in HHS, it can be variable. So DKA also has degrees, and this is important when triaging the patient. So mild DKA would be associated with a bicarbonate of 15 to 18 and an arterial pH of 7.25 to 7.3 in a patient with normal mental status. Moderate DKA is usually associated with bicarbonate of 10 to 14, pH 7.0 to 7.24. The patient can be alert or have some mental impairment. And severe DKA is seen when the bicarbonate is below 10, pH below 7. The patient will often in this setting have stupor or coma. Remember that serum bicarbonate levels may underestimate bicarbonate deficit when in severe volume contraction, and when you expand volume with fluids, there may seem to be a drop in bicarbonate, and this should not be interpreted as a sign of worsening of the underlying acidosis. What is the pathogenesis of DKA and HHS? Insulin target tissues to review are liver, muscle, and adipose tissue, and on these tissues, insulin action is to decrease glucose production, increase glucose uptake, decrease lipolysis. And it is important to know that less insulin is needed to suppress lipolysis. Only about a tenth of the insulin is needed to suppress lipolysis than is needed to suppress gluconeogenesis, so that when ketosis is present, there is a more severe degree of insulin deficiency. The counterregulatory hormones are glucagon, epinephrine, cortisol, and growth hormone. These counterregulatory hormones antagonize insulin effect on glucose and free fatty acids. Also of note is that glucagon, which is produced by alpha cells in the islets, will increase if beta cells are deficient in producing insulin. So insulin produced in the beta cell will suppress glucagon, and in the absence of insulin from the beta cell, glucagon levels will tend to rise and antagonize insulin action on glucose and lipolysis. So what is the underlying pathogenesis of DKA and HHS? Dehydration will occur when hyperglycemia promotes osmotic diuresis and fluid intake is inadequate to keep up with the losses. This can be seen particularly in immobility, dementia, use of diuretics, gastrointestinal illness. Ketosis will occur when insulin is low and the counter-regulatory hormones are elevated. And as I said, free fatty acids are metabolized to ketone bodies, acetone, acetoacetate, and beta-hydroxybutyrate. What is the epidemiology? DKA is estimated to account for 140,000 hospitalizations in the US and 500,000 hospital days. HHS is less common but has a higher mortality. Mortality for both conditions has been decreasing as we have improved our management. And here you can see over time, this is quite small, I realize, but starting in 1980 and going up to 2009, we can see a drop in mortality from hyperglycemic crises. So what are some of the precipitating factors for DKA and HHS? New onset diabetes can account for up to 50%. Medication noncompliance accounts for about a quarter. Perhaps another 20 to 25% will have an infection. 2 to 5% of patients presenting will have had a cardiovascular event. 5% will have pancreatitis. New use of drugs such as glucocorticoids can cause this, and some of the newer antipsychotics have been associated with hyperglycemic crisis. And substance abuse coexists in 25 to 50% of patients. Several of these precipitating factors can coexist for any one patient. What are the primary clinical features that we see? So the symptoms of dehydration can include polyuria, polydipsia, fatigue, dry mucous membranes, hypotension, and neurologic symptoms, which can include focal abnormalities such as seizures, lethargy, and coma. Ketoacidosis symptoms can include abdominal pain, nausea, vomiting, which should, if the abdominal symptoms are excessive, secondary cause of these symptoms should also be investigated, but they can, in mild form, be associated with the ketoacidosis. Rapid, deep, and labored breathing can be associated with ketoacidosis, and fruity breath. What are initial labs to be ordered? Plasma glucose, BUN creatinine and electrolytes, serum ketones and urine ketones, arterial blood gas, osmolality, CBC, and any labs that are indicated or imaging to determine cause of the crisis. So here are some handy formulas for evaluating the laboratory abnormalities. So most labs will give you an anion gap, but if yours doesn't, normal is about 10 to 16. If we calculated our patients, it would be 121 minus the 15 plus 80 equals 26. So elevated anion gap. Calculating effective serum osmolality. This is 2 times the measured sodium plus the glucose over 18. So in our patient, that would be 2 times 121 plus 840 over 18 is 289, would be her effective serum osms. Her osmolar gap is her actual measured osms minus the calculated osms. And for the calculated osms, I know this is getting a little complicated, but you have to include the BUN for calculated osms, and that would be the BUN over 28. In our patient, it would be 311, which was the measured serum osm, minus 301, which would equal 10. Normal osmolar gap is 2 to 3. So this is mildly elevated. And finally, corrected sodium, normal being 135 to 145. Previously, it had been felt that the sodium could be corrected by multiplying the glucose level by 0.016. However, more recent data shows that 0.024 times the glucose minus 100 is more accurate correction for the serum sodium. So using that in our patient, we have a corrected serum sodium of actually 139. What are some of the laboratory pitfalls that you should be aware of? First, lipase levels can be falsely elevated if the assay measures glycerol, and glycerol can be very elevated in DKA. So you should know if this is possible in your lab. Creatinine can be falsely elevated by the ketones, depending on the method used to measure it. And as I had mentioned earlier, nitroprusside reactions for ketone bodies will not detect beta-hydroxybutyrate, which is the earliest ketone to appear. So this should be ordered separately. And here you can see in very small letters, I realize acetyl-CoA going to acetoacetate, which then is metabolized to beta-hydroxybutyrate and acetone. And you can see those structures there. What about the differential diagnosis of an anion gap acidosis? In DKA, we know that we have elevated glucose, elevated hydroxybutyrate. The osmolar gap, as in our patient, can be mildly elevated, but not excessively so, because the ketones will be osmotically active. And lactic acid, of course, would not be elevated in DKA. In alcoholic ketoacidosis, generally the glucose level would be normal, although this becomes very confusing in patients who have diabetes and alcoholism. Beta-hydroxybutyrate is elevated. Osmolar gap, again, can be mildly elevated. Lactic acid is normal. One study has recently mentioned that the ratio of beta-hydroxybutyrate to acetoacetate is 7.1 in alcoholic ketoacidosis, but 3 to 1 in diabetic ketoacidosis. So this may be of help in that patient with diabetes and alcoholism. For salicylate, glucose beta-hydroxybutyrate will be normal. The osmolar gap can be mildly elevated. Lactic acid is normal. Lactic acidosis, of course, is characterized by a lactic acid level of greater than 5. And then the more difficult one are toxin ingestions. Here, normal glucose and beta-hydroxybutyrate, but a high osmolar gap. And that can be accounted for by methanol, ethylene glycopyrrolidhyde, and isopropanol. So now going to treatment for patients with a hyperglycemic crisis. The treatment should involve fluids, electrolytes, insulin, and search for a cause. So causation should be investigated simultaneously with the initiation of treatment and should include CBC cultures, EKG, liver function tests, and imaging as appropriate. So what about management with fluids? Fluid deficits can be substantial. So in DKA, fluid deficits are in the 3 to 5 liter range. In HHS, because the primary deficit is dehydration, fluid deficits can be very high. Fluids should initially be replaced with normal saline, about 1 liter per hour, or 15 to 20 cc's per kilogram per hour, and this should occur for at least the first hour. Only in patients with heart failure and end-stage renal disease should that be modified. The goal of the initial fluid therapy is to restore plasma volume, this can be determined by improvement in blood pressure and urine output of 50 cc's per hour or greater. Once volume replacement with normal saline has occurred, subsequent fluid choice is based on corrected sodium. And again, I showed you that formula earlier with the new correction for sodium. Use half normal saline if your corrected sodium is greater than 135, but continue using normal saline if the corrected sodium is less than or equal to 135. And again, this should only be done after plasma volume has been restored with the normal saline. In HHS, rapid correction of hyperosmolarity is not recommended, so transitioning to hypotonic solution should be perhaps more conservative than in DKA. But for both conditions, dextrose should be added when the glucose comes down. In DKA, when it reaches between 200 and 250 milligrams, glucose should be added to the fluids. And once you get to about 300 milligrams in HHS, glucose should be added to the fluids. I just would like to mention fluid replacement in children. Cerebral edema is a rare complication of DKA in children. Large initial volumes of fluid have been associated with an increase in risk for cerebral edema. So the suggested response is to avoid the decrease in effective plasma osmolality for at least 15 hours of treatment through continued use of normal saline. And this should help prevent this complication. Now let's turn to potassium. This just reviews how potassium is maintained in the intracellular space. There's sodium-potassium pump, which will bring potassium in and exchange for sodium. There is also a hydrogen-potassium exchanger in which hydrogen ions and potassium ions are exchanged. Insulin is a prime driver of the sodium-potassium pump. So when insulin is added, this pump will become activated and will drive more potassium into the cells. Also, as hyperglycemia is resolved and acidosis is resolved, there will be less of an exchange of hydrogen ions for potassium ions. And both of these effects will tend to lower extracellular potassium levels. So as I said, insulin and sodium bicarbonate can lower potassium significantly. Neither insulin nor bicarbonate should be administered until a potassium level is available, because their acute administration in a hypokalemic patient could produce serious further hypokalemia. In all patients with a hyperglycemic crisis, assume that potassium depletion exists, except for perhaps that small group who have end-stage renal disease. And while waiting for the potassium level to come back, just remember that fluids will help lower the glucose initially, and these can be started before insulin is administered. Once a potassium level is available, if it falls in the range of 3.3 to 5.2 milliequivalents, put 20 to 30 MEQs of potassium per liter in all IV fluids. whether it's normal saline, half normal saline, or D5 half normal saline containing D5 half normal saline fluids. If, on the other hand, the initial potassium comes back less than 3.3, potassium should be given 20 to 30 MEQs per hour through a central line, and the patient should be monitored closely in the ICU. Insulin, fluids can be given, but insulin should be withheld until the potassium is 3.3 or higher. The goal for potassium maintenance is 4 to 5 milliequivalents per liter. Potassium, again, should be used with caution in patients with significant renal impairment. What about bicarbonate and phosphate? In general, bicarbonate is not recommended, and as I showed before, it can worsen hypokalemia. However, if pH is 6.9 or lower, cautious supplementation can be considered. For phosphate, you will find that both insulin and fluid replacement will tend to lower the serum phosphate. Phosphate replacement is not felt to be necessary unless the phosphate is below 1 milligram per DL. If possible, milk is a good source of phosphate if the patient can take this PO, or if absolutely necessary, phosphate can be given as potassium phosphate IV. Now let's turn to starting insulin. IV regular insulin therapy is preferred to giving sub-Q therapy if the patient is going to be otherwise managed in the intensive care unit. Initial IV insulin dosing should be a 0.1 unit per kilogram as a bolus, and then 0.1 unit per kilogram per hour as a drip. The bolus can be repeated one time if the glucose does not drop after the first hour. But no bolus should be given in the hypokalemic patient. IV insulin should not be given as a bolus for children. The drip should be adjusted to lower glucose 50 to 75 milligrams per hour. If the glucose is dropping at that rate, there is no need to increase the insulin drip. Glucose should be checked hourly, and the glucose should be targeted to 150 to 200 in patients with DKA, and 200 to 300 in those with primary abnormality of HHS. What about using sub-Q insulin? Subcutaneous regimens have been developed for mild to moderate DKA, not for severe DKA. Some of these include using 0.2 units per kilogram of a rapid-acting analog initially, and then giving 0.1 unit per kilogram each hour, or 0.2 units per kilogram every other hour until blood sugar is below 250 milligrams per DL. Once blood sugar gets below 250, the sub-Q dosing should be cut in half until resolution of the DKA. However, sub-Q insulin should not be used in severe or complicated DKA and never used in HHS, where the patients are severely dehydrated and will not absorb sub-Q insulin. Eventually, all patients with resolution of their hyperglycemic crisis will need to be transitioned to subcutaneous insulin. In order to do this, ideally the patient should be clinically stable and able to eat. They should also have resolution of the episode by laboratory studies. So in patients who have DKA, the glucose should be below 200, and the patient should have 2 of 3 of the following: a bicarbonate greater than 15, a venous pH greater than 7.3, or an anion gap less than 12. It should be remembered that sodium chloride containing fluids can lead to a phase of hyperchloremic acidosis without an anion gap. In HHS, the serum osms should be at least below 315 with a normal baseline mental status. When transitioning a patient to sub-Q insulin, a total daily dose of 0.5 units per kilogram per day is a standard starting dose. This can be split to be given 50% as a long-acting basal insulin and 50% divided among meals. This is called the weight-based method. When doing this, the insulin drip should be continued for at least 2 hours after giving a rapid-acting insulin and basal insulin. Again, longer overlap will help prevent rebound hyperglycemia. Correctional insulin should be started after the drip is stopped. For patients who have established insulin doses who developed a hyperglycemic crisis, those doses, as felt to be appropriate, can be restarted rather than using the weight-based method if felt to be appropriate. What about improving transition from sub-Q to IV insulin? The main problem with transitioning patients off of IV insulin is the rebound hyperglycemia. In a recent study, 60 patients on IV insulin were randomized to either early basal insulin, meaning within 12 hours of starting the drip, or the conventional insulin, meaning 2 hours prior to stopping IV insulin, the patients received subcutaneous insulin. And this study was done in patients with DKA as well as post-op patients and patients on high-dose steroids. In this intervention, the patients received 0.25 units per kilogram per day of the basal insulin in addition to their IV insulin drip. And what they found is after the transition, 33% of the intervention group had rebound hyperglycemia compared to 90% of the conventionally treated group. So while this approach has not been fully accepted, earlier use of basal insulin and longer overlap with IV drip can be quite effective at preventing rebound hyperglycemia. What are some of the complications of management of DKA and HHS? So as I've been mentioning, hypokalemia is frequent and can be quite dangerous. Hypoglycemia also occurs. It is avoidable if the patients are adequately monitored. Hypophosphatemia usually does not require treatment, though it will be quite common if you order laboratory studies looking for it. Cerebral edema occurs in up to 1% of children, but it's very rare in adults. And as I mentioned, its cause isn't known, but avoiding rapid lowering of plasma osmolality may help prevent it. When it does occur, mortality is up to 70%. It can be quite devastating. What about developing a specific DKA HHS protocol for your institution? Will having a protocol to follow be helpful? This is a study that looked at 241 DKA patients, and they looked both before a protocol was developed and after. They looked at length of stay, stay in the ICU, and time to anion gap closure. And as you can see here, the hospitalization was shorter, time in the ICU was shorter, and time to anion gap closure were all shorter after this institution developed a computerized protocol for management of DKA. So how can you develop a protocol? First, your institution should develop a treatment guideline, then create an order set. The staff will need to be educated in the use of the order set. It should be trialed, and often adjustments are needed. And then mechanisms should be in place to assess the long-term outcomes using the protocol. So what happened to our patient? Just to go back to her, she was treated with IV fluids, IV insulin, bolus, and an insulin drip, and potassium. Ultimately, she was able to be transitioned to sub-Q insulin and was discharged home. Within 2 months, she was on metformin alone. And I think she illustrates the phenomenon of ketosis-prone type 2 diabetes, and up to 30% of African American or Hispanic patients with DKA will actually have type 2 diabetes, not type 1 diabetes. So now let's switch gears at the end here to talk about management of non-critical hyperglycemia in the ICU. So definition of terms. Hospital hyperglycemia is felt to be any blood sugar over 140 milligrams per DL. In stress hyperglycemia, elevations in blood glucose are noted that occur in patients without a prior history of diabetes and who also have A1C levels that are not elevated, meaning below 6.5%. If they have an A1C equal to or higher than 6.5%, it implies that their hyperglycemia may actually be due to diabetes that was undiagnosed. Previously, a definition of hypoglycemia was any blood sugar in the hospital less than 70, and severe hypoglycemia was, in many studies was a blood sugar below 40. However, the American Diabetes Association has revised these criteria. Now, in the hospital, blood sugar below 54 is felt to be represents serious hypoglycemia, and any patient with a glucose value below 70 and cognitive impairment is felt to have severe hypoglycemia. So the definitions are a little bit in a state of transition. So why control blood sugar levels in the intensive care unit? This is a large study that looked at in-hospital mortality and mean blood glucose in patients in green without known diabetes and in patients with known diabetes. And we can see that there is a sweet spot with the best mortality in both diabetics and non-diabetics in this 90 to 120 range. What's also apparent is that patients with no prior history of diabetes but marked hyperglycemia have very high in-hospital mortality rates in the setting of a myocardial infarction. So what could be the link between high blood glucose and poor outcomes? Metabolic stress increases counterregulatory hormones, which leads to an increase in glucose, lactate, and free fatty acids. These metabolic changes can contribute to immune dysfunction, increase reactive oxygen species, and ultimately lead to poor healing and tissue damage and apoptosis. So what would happen if to mortality in patients where hyperglycemia was corrected? So this is some data from a study, a single-center study that looked at treating patients in a surgical intensive care unit with IV insulin infusion to maintain their blood sugar in the 80 to 110 milligram range, compared to the conventionally treated patients where blood sugars, the goal for blood sugar was to be below 200. And what this study published in 2001 showed was a marked improvement in mortality, both in the ICU and overall in-hospital survival with insulin infusion maintaining blood sugar in the 80 to 110 range. So this led to a lot of excitement and many trials, and also a change in practice. However, a later study that was a multi-center trial involving both surgical intensive care patients and medical intensive care patients looked specifically at targeting glucose levels in the 80 to 110 range compared to blood sugars in the 140 to 180 range. And much to the surprise of the study and the world, the survival was better in those patients with blood sugars maintained in the 140 to 180 range rather than those in the randomized to the lower blood sugar range. Hypoglycemia was much more common in the intensively treated patients than in the conventionally treated patients in this study. So could hypoglycemia be the driver of the higher mortality? This was a later analysis of the data from the NICE sugar study. And again, I think what it can show you is how much more common hyperglycemia was in the intensively treated group than in the more conventionally treated group. And for patients who did have hypoglycemia, it is clear that it was a major risk factor for mortality. So on the basis of this data, the major professional societies have changed their recommendations for management in the ICU setting. So current recommendations are that starting at a threshold of no higher than 180 for patients in the ICU, there should be initiation of IV insulin therapy. Once IV insulin therapy is started, the target glucose level should be 140 to 180. For some patients, lower glucose targets such as 110 to 140 may be appropriate, especially in surgical patients in whom this target range appears to be of benefit. And targets below 110 or greater than 180 are not currently recommended at this time. So what are some of the advantages of an IV insulin infusion protocol in the ICU? So it is useful for covering basal insulin requirements. It helps maintain glucose in a pre-specified range. It can be easily adjusted as patient needs change. There are several protocols out there, and most are felt to be equivalent as long as the nursing staff is adequately trained in the use of the particular protocol. With the higher goals that are now recommended, there is a very low risk of hypoglycemia when these protocols are properly followed. What are some disadvantages of using IV insulin in the ICU? So it is technically difficult and requires a lot of nursing time, especially because glucose values need to be checked every hour. IV insulin does not address the prandial needs of a patient. So when patients start with intermittent feeding, if they are stable, they should be considered to transition to sub-Q insulin. However, if a patient is not stable enough to transition to sub-Q insulin, but is going to be intermittently fed, consider adding rapid-acting analog insulin sub-Q before meals to help prevent some of the postprandial excursions that are seen when patients are on an IV drip alone. And of course, the final disadvantage of IV insulin protocols is that they always have to be transitioned to another form of insulin delivery for long-term glucose management. Now I'd like to turn to a new controversy, point-of-care glucose testing in the ICU. So these IV insulin protocols require point-of-care testing. Point-of-care testing with conventional glucose meters in critically ill patients is not FDA-approved use of the technology. So federal government agencies may move to require further testing in the ICUs for approval for routine use. The federal government has not actually defined what they mean by critical illness. So this has presented somewhat of a dilemma. What is known about accuracy of point-of-care testing? So in general, the meters are required to show that 95% of their values are within 20% of reference. However, most meters do far better than this. In the outpatient setting, it is clear that 99% of values are within 20%, and the median difference from reference range is only about 5% for the average meter on the market. Blood gas analyzers are actually more accurate for doing point-of-care testing, but require arterial blood and are not always available. You should also remember that arterial glucose is always higher than capillary, and which is higher than central venous glucose. So if different sources of blood are used for point-of-care testing, different values can be obtained. In hypotension, the decreased perfusion leads to increased glucose utilization and a greater difference between arterial and venous glucose. What are some known sources of inaccuracy in point-of-care testing? In the intensive care unit, extremes of hematocrit can affect point-of-care testing. So if the hematocrit is below 20%, it may overestimate glucose. Above 70%, it may underestimate glucose. Markedly elevated triglycerides, bilirubin, and uric acid can impact glucose measurements. Severe acidosis can affect it. Hypothermia can cause falsely low glucose values. And what about drugs? Acetaminophen, especially in overdose setting, can raise glucose level by point-of-care testing. Ascorbic acid will falsely lower it. And there have been several cases where non-glucose sugars have been read as glucose, resulting in excessive insulin dosing. This occurs with only a few types of glucose meters. The glucoses, sugars that can be involved include maltose, galactose, dextrin, and mannitol. If using one of the types of meters that will measure these, that meter should not be used in this setting. Dopamine also will falsely increase point-of-care testing glucose levels. So in summary, DKA and HHS may have significant overlap in laboratory findings. Treatment should proceed on several fronts simultaneously. Protocols may help improve outcomes and standardize care. Goals for glucose in the ICU have been evolving. Hypoglycemia is associated with an increase in mortality, and point-of-care testing may be impacted by conditions common in the ICU. So let's discuss some questions. Initial management of DKA or HHS usually includes which of the following? Half normal saline, IV insulin bolus of 0.2 units per kilogram body weight, 2 amps of sodium bicarbonate and 400 cc's of sterile water over 2 hours, or a search for precipitating cause. So always search for precipitating cause when a patient presents with a hyperglycemic crisis. Initial fluids should be normal saline, not half normal saline. Initial IV insulin bolus is 0.1 unit per kilogram body weight, and bicarbonate at this dose should not be used in general. Which of the following are not complications of treatment for DKA or HHS? Hypokalemia, renal insufficiency, hypoglycemia, hypophosphatemia, or hyperchloremic acidosis. So renal insufficiency, I've shown you how hypokalemia is a very common occurrence. Hypoglycemia also is common. Hypophosphatemia and hyperchloremic acidosis are frequently seen and do not require treatment. Question 3, stress hyperglycemia is associated with increased mortality in patients with myocardial infarction, seen in patients with A1C levels over 6.5%, usually treated with metformin, a permanent condition, or indicated by a glucose greater than 110. So stress hyperglycemia is associated with increased mortality in patients with MI. In patients with an A1C greater than 6.5% and hyperglycemia in the hospital, diagnosis of diabetes should be made. Metformin is not the initial therapy for stress hyperglycemia. Insulin should be used. Stress hyperglycemia is not a permanent condition. It will resolve when the stress resolves. And the threshold is a blood sugar over 140, not over 110. These are some references, and I would point out that a discussion of hyperglycemic crises that's been recently updated, I think you will find quite helpful. I have no disclosures.